Okay, so last time we were looking at the different factors that affects the cardiac physiology or cardiovascular system physiology, including blood volume. So blood volume has different factors, including the presence of certain hormones and the hormones, how they affect the retention of fluids or the state of the blood vessels, like whether they are vasodilated or vasoconstricted. So we have there an example of a hormone or three chemicals, three endocrine factors. So we have angiotensin 2. Angiotensin 2, it's a powerful vasoconstrictor that comes from the actual conversion of a molecule that it's a precursor that is called angiotensin 1. Now, angiotensin 1 comes from a large polypeptide that we have in the bloodstream that is called angiotensinogen. And this large polypeptide is inactive. So it gets activated when it's chopped down into smaller pieces by an enzyme that is called renin. And this one is produced by the liver. So there is a cascade. So renin is released when someone has low blood pressure. Then this is the triggering event. So you have drop in the blood pressure. Then you lead to release of renin. That will lead to angiotensinogen to be converted into angiotensin 1 and then angiotensin 1, it will be converted into angiotensin 2 and this happens in the lungs. Put a bracket here. We will see this again in the urinary system, but basically this conversion happens because we have an enzyme that is called angiotensin converting enzyme, and this by itself will make your blood pressure to go up because it's a vasoconstrictor. It helps for your blood vessels to become tight, and then that leads to release of aldosterone. Which this one leads to sodium and water retention. by the kidneys. That increases the blood pressure. So this is called the RASS, renin-angiotensin-aldosterone system cascade to increase the blood pressure. So we have in the kidneys then sensors for or bioreceptors that can detect change in blood pressure. So if blood pressure drops, then you undergo that cascade. And as well, you release ADH, which help you to retain fluids because you will go less to pee. That's part of these mechanisms that increases blood volume, and when you have more blood volume, you have higher blood pressure. And then let's say that someone accidentally receives extra fluids by an IV line inadvertently. So in this case, you have excess of volume. That excess of volume is going to return into the right atrium. Right atrium is going to extend more, and it's going to lead to the release of atrial natriuretic peptide, or ANP. ANP is going to lead to the excretion of sodium by the kidneys, and since sodium pulls water, you will lose blood volume. That is like the most common way where someone can have excess of volume. Don't think like because you drink a lot of water, you will retain more fluid. You will go more in pee, unless you have kidney problems, like renal failure. But other than that, if you have excess of body fluid, atrial natriuretic peptide will be released. Then you decrease the retention of water, so you pee more, and then you have decrease of blood volume and decrease of blood pressure. Any questions about the physiology of blood pressure and blood volume? Now, for the capillaries. So the capillaries are the smallest blood vessels that we have, and you only have tunica intima. The tunica intima will be this, and the cells of these capillaries, which are the endothelial cells, are simple squamous. So it's a single layer of cells, and these cells are flat. And they are attached into this basal lamina, and in between you have some cells that are called pericytes, in between the basal lamina and these endothelial cells. Now, the diameter, or side-to-side width, will be between 8 to 10 micrometers, so it's very small. It fits erythrocytes. So this is a photomicrograph of a capillary within tissues, and then they fit exactly the size of the red blood cells, which is like around 8 micrometers in diameter. And they stack like if they were dinner plates, and this helps to push from proximal to distal the blood flow so that the blood flow continues, and then you have exchange of gases and nutrients and fluids within this area. And some erythrocytes, they can flex, and they fit much efficiently, they flow much better because they don't have a nucleus. We will see that in the next chapter. So we have different types of capillaries. We have some capillaries on which these cells, like the endothelial cells, are next to each other, and you have tight junctions in between the cells. So that helps to seal more or less the capillaries. Not perfectly sealed, but still you don't have a space that is large between the cells. So these capillaries are called continuous. Where do we have them? In the skin, most of the nervous tissue, and connective tissue in our body, and in our muscle cells. They are the capillaries of the different types that we have, the ones that are less porous or less leaky. And they allow the passage of oxygen, nutrients, CO2 through these cells. Now, the next set of capillaries that we have are called fenestrated because they have pores in between the cells, in the cells. So these pores are called fenestrations. Where do we have them? In the kidneys, endocrine glands, and the small intestine. So they are more leaky than the continuous ones. And they allow the passage of large volumes of fluid and larger substances that can cross through these fenestrations. The other type of capillaries that we have are called sinusoidal, and they have large pores and large spaces in between the endothelial cells, and they have a discontinuous basal lamina or basal membrane. So we have it in places like the liver, lymphoid organs, bone marrow, and the spleen. So these are areas where large proteins, or even sometimes entire cells, like in the case of the bone marrow, go through. So that's why we have these large gaps, so to allow the passage of large molecules. So those are the three types of capillaries that we have: continuous, fenestrated, and sinusoids. Any questions? The most leaky will be the sinusoids, the less leaky, the continuous, and the ones in between will be the fenestrated.
So, Professor, the fenestrated are only in the small intestine because that's where all the absorption of nutrients happen?
Mm-hmm. Exactly. And then how the molecules move across the capillary. So if you magnify a piece of capillary and you see these cells, so in this case, this is a fenestrated capillary. And then here we have one cell, another cell, and another cell. So in between the cells, you have some gaps in which you have osmosis and diffusion. And as well here in this fenestra, or these little gaps. Now, through the plasma membrane of these endothelial cells, you have diffusion of oxygen and CO2, while in this case, between the gaps, either the fenestrae or the gaps between the cells, you have the passage of large molecules. So small molecules through here and large molecules through here. The bigger the opening, the larger the molecule that can go through. So molecules can come in and out, like, for instance, CO2 can come in, oxygen can come out in this, and then hormones can go through this fenestrate, through this gap, or ions. And then you can have as well transcytosis. So basically you can have molecules trapped within this plasma membrane, enclosed within these vesicles, and then you can exocytose these molecules. Like if you want to transport many molecules at once, rather than through here, you can do this transport. That's called transcytosis. Now for the blood flow through the capillaries. So the capillaries are branches of the arterioles. So these are arterioles. These are the smallest arteries, and this is a capillary. So the capillaries, which are these branches, and this is another capillary, but this specifically, it is called thoroughfare channel because blood can go directly from this arteriole to this venule. But these capillaries that are branches of this, they will have sphincters or these circular layers of smooth muscle cells that when they contract, they prevent the blood flow into the capillaries, and when they open, they allow the blood flow here. So there is an advantage of having these sphincters. You can send the blood to more vital organs when necessary by shutting down the blood flow to the capillaries of organs that don't need the blood. Let's say that someone unfortunately has a hemorrhage, and then a tissue that definitely always needs blood flow will be, or blood supply will be the brain. So in this case, the capillaries for muscle cells can shut down the blood supply by contracting these myoepithelial cells of the sphincters, and then the blood can go directly from the arteriole into the venule and then going into the brain. But let's say that you don't have a hemorrhage, but then you start working out your biceps rather than your leg muscles. In this case, you can shut down the capillaries in your, most of them, not all of them, of course, in your muscle cells from your legs than the ones from your biceps. Because you have more activity, then you relax these myoepithelial cells, these sphincters, and then you have more blood supply, and then you have growth of the tissue because you're working out your biceps. So there is always regulation. The active tissues will have more blood supply than the less active tissues. And then blood flow always have to go from arterioles to capillaries and to venules, not the other way around. Okay? And the capillaries have two endings. They have an ending that is close to the arteriole. In this case will be more oxygenated blood. So this will be the arterial end. And they have an ending that is closer to the vein, that it has less oxygen. So this will be the venous end. And in here, in the arterial end, you have more secretion, while in the venous end, you have more absorption. But you have secretion and absorption. So we will see how does that work. So here we have an arteriole, here we have a venule, and here we have a capillary that is extended, how it connects from arteriole to venule. And we have different forces that drives secretion and absorption. So next to this arterial end, we have secretion because we have blood here that has more high water content. And that high water content leads to hydrostatic pressure, moving fluids, water, plus dissolved solids like ions, hormones, nutrients, out of the capillaries into the extracellular space. And you have cells here that receives this fluid, rich in nutrients, rich in oxygen, and then picked it up. So you have around 35 millimeters of mercury of hydrostatic pressure driving water out. And then you have proteins here in your blood that tends to bring water in. But that pressure, that colloid osmotic pressure, or COP, is less than the hydrostatic pressure. So it's 22 versus 35. So are more forces that are pushing the fluid out than bring it in. 35 minus 22, how much it is? 13, it's in here. That's NFP, net filtration pressure. So because you have 13 millimeters of mercury, that pressure moves the water and its solutes out into the extracellular environment. And then this blood, as it's moving from arterial end to venous end, will have more proteins and less water. Now you will have a reversal in forces because the colloid osmotic pressure tends to pull the water into a compartment. In this case will be the intravascular compartment or the compartment inside the blood vessels, which in this case is going to be the lumen. So then you will have 15 millimeters of hydrostatic pressure, so you have less water. So then water will tend to come out less. And you have colloid osmotic pressure, which is basically the proteins that we have in the blood that are concentrated because you have less water, of 22 millimeters of mercury. What is going to be the difference? 15 minus 22, you have a deficit. You have minus 7 millimeters of mercury. That will move the water in at the venous end. So that's the net filtration pressure. So you have inward flow and outward flow in here. And then our cells typically are very generous. So you have excess of fluid here in the interstitial fluid, and that excess of fluid is going to be picked up by a set of blood vessels that are called lymphatics that we will consider in the next chapter. So what is the overall net filtration pressure? So you take the net filtration pressure from the arterial end and subtract it from the net filtration pressure that you have here in the venous end. So that will give you 13 minus 7, 6 millimeters of overall net filtration pressure. So you have a physical force that moves more fluids out than in. And that's why fluid stays in here, keeps our cell moisturized, and now the excess of fluid needs to be picked up by the capillaries, lymphatic capillaries. Questions? If you have a bank account, when you're balancing, put more, withdraw less, you have savings. So that's what is going to happen in care. Okay, so that's the physiology of capillaries. Now let's move into specific blood vessels, their names, their location, and what organs do they supply in the body. So, blood vessels, all arteries derive, all the arteries derive from the aorta, which is the main artery that exits the left ventricle. So, one of the branches of the aorta is the common carotid. The common carotid runs on the neck area together with the internal jugular vein on the sides of the trachea and the larynx. And it gives some branches, like the common carotid gives the superior thyroid artery that provides blood supply to the thyroid gland. These two that are found here on the sides of the neck, on the sides of the trachea, they are running together, it's not shown in there, with vagus nerve, cranial nerve number 10. They form a neurovascular bundle. So this is not to give you bad ideas, but when someone wants to commit suicide, it's not going to slash this area. because here we don't have as much blood pressure. So the blood vessels in here, when they are cut, they collapse. But in here, in the neck area, unfortunately, these have a lot of blood supply, each of these two, that the person, if it doesn't hit the carotid, it will hit the internal jugular vein, and if not, it will hit the vagus nerve, and it's going to create problems with the heart. So it has 3 chances in 1. So then this common carotid is going to bifurcate at the level of the mandibular angle into external carotid that is going to run on the surface of our face anterior to the ear, and also is going to bifurcate into the internal carotid that is going to run in the carotid canal of the temporal bone, and is going to provide blood supply to the middle part of our brain and anterior part of our brain with these branches, the internal carotid. Now, the external carotid is going to form superficial branches that are going to provide blood supply to the scalp, like the temporal artery. And then here you have the temporal vein that runs here on the sides of our temple. And then you will have the facial artery and facial vein. So this facial artery is going to provide blood supply to this area of the face. And then you have the maxillary artery and the vein that is going to provide blood supply to this area of the face. Now, the ophthalmic artery is going to be a branch of the internal carotid, and it's going to provide blood supply to this area, the area of the eye. And then we have other branches like the lingual artery that provides blood supply to the tongue. So those are branches of the external carotid. And now, draining blood from the scalp and the face will be the facial vein that is going to drain the blood into the internal jugular. And then we have the temporal vein that is going to drain the blood supply from the scalp area on the sides of our scalp, or of our skull, sorry. And that is going to drain into the temporal vein. The temporal vein is going to drain into the external jugular. And both of these jugulars, the external, which runs here on the surface, they remove here the sternocleidomastoid, which is this muscle, but runs on the surface of the sternocleidomastoid. But both the external jugular and the internal jugular drains into this blood vessel that is called the subclavian. Why is it called subclavian? This is subclavian vein because it's underneath the clavicle. Clavicle, sub, under. So both of them drain into the subclavian. And then the subclavian is going to change its name into brachiocephalic, and the right and the left brachiocephalic will form the superior vena cava. So everything from the diaphragm and above is going to be drained by the superior vena cava, while everything below the diaphragm is going to drain the blood into the inferior vena cava, into the right atrium. And then here, branches of the, or branch of the subclavian artery, which is this, it is the vertebral artery. The vertebral artery runs in the transverse foramina of the cervical vertebrae, the vertebrae that we have in our neck. That's the only vertebrae, if you remember, that has these holes that in the transverse process that allows the passage of the vertebral artery, and also it lets the drainage of blood from the posterior area of the brain through this vertebral vein. So this vertebral artery anterior in the pons is going to merge the left and the right. It's going to form a single vein that is going to be called the basilar artery. And that basilar artery is going to provide blood supply to this area of the brain, the occipital area. So this is the head and neck blood vessels. So this is the layout view of just the arteries. So here we have the subclavian, vertebral, common carotid. Here is the internal carotid running through this carotid canal. And then in here we have this basilar artery, branch of this vertebral artery. And then here is the ophthalmic, that is branch of this internal carotid. And the internal carotid is going to give the middle cerebral artery that is going to provide blood supply to here, and the anterior cerebral artery that is going to provide blood supply to this, like the frontal lobe, for instance, and this one to the temporal lobe. And then the basilar artery is going to give the posterior cerebral that is going to provide blood supply to the posterior area of the brain, including the cerebellum. So here we have posterior cerebral artery, middle cerebral artery, anterior cerebral artery. These two branches of the internal carotid, while this posterior branch of the basilar, which is a branch of the vertebral, which is a branch of the subclavian. And these two are branches of the brachiocephalic. Brachio because it's going to provide blood supply to the arm, and cephalic because it's going to provide blood supply to the brain. Any questions? This is a view of the brain arteries, now the inferior view. So here we have medulla oblongata, here's the pons, and spinal cord. So this is the left and right vertebral that anastomose is joining to form a single blood vessel, anastomosis. So this is the basilar artery. And then the basilar artery is going to provide blood supply to the pons, and it's going to give rise to this posterior cerebral. And then here we have the internal carotid that is going to give this middle cerebral artery. And then here we have the anterior cerebral artery. Now, it's not shown in here, but in this area we have the pituitary gland. And around the pituitary gland we have a runabout of blood vessels that is called the polygon of Willis. That it is made by the middle cerebral artery, the anterior cerebral artery, the posterior cerebral artery, and the communicating arteries, which are these. And then these two runs here in between the left and the right hemispheres, the anterior cerebral arteries. And then with these little branches, they provide blood supply to all this tissue. So here is the circle or polygon of Willis. Basilar artery, posterior cerebral artery, branches of the basilar. And then we have the posterior communicating that communicates this posterior cerebral with the middle cerebral. And then we have the anterior communicating that communicates the middle cerebral with the anterior cerebral. And again, we have here the pituitary gland. So it's basically the blood vessels running about the pituitary gland. So these provide blood supply to the posterior area of our brain, this to the middle area of our brain, and this to the anterior area of our brain. Why do you think we have this type of arrangement of blood vessels? Why they are communicating? What is the physiological advantage of having this?
If one gets blocked off,
The rest can run about. Yeah, if one of these already get blocked off, there's still hopefully some circulation going around. Not perfect, but better than nothing. So then when our blood goes in our brain, the arterial blood, and provides the oxygen and the nutrients, then the blood will be returned into different blood vessels in our brain, including blood vessels that runs between the dura mater, the meninges in our brain that are called dura mater. So this will be the superior sagittal sinus. So this is located in the mid-sagittal suture, or well, not suture, the false cerebri. So then you drain blood into a superior sagittal sinus, and then you have these cerebral veins that drains the blood from here into these blood vessels in here, including the cavernous sinus. And then you will have blood coming into the straight sinus from this inferior sinus into the straight sinus, and then into this transverse sinus, and then into the sigmoid, and then into the internal jugular vein. So this is why out of the difference, if you remember, when we were looking at the different type of pressure that we have between arteries and veins, like arteries, they have like the largest arteries, like 90 millimeters of mercury, and the veins like around 5 millimeters of mercury. It's not a lot of pressure. But by gravity, this internal jugular vein, which is part of the venous system, and by lots of blood supply that it is drained from the brain tissue, because it's the tissue that receives more blood supply per gram than any other tissue in our body, because we have a lot of blood supply from the brain coming into the internal jugulars, and by gravity, if the person is standing, this is one of the exceptions where these blood vessels can bleed a lot. And it doesn't have to have like a lot of blood pressure. So again, here we have superior sagittal sinus. Here we have the cerebral veins. So this drains blood into this area, including this cavernous sinus. Then you have the inferior sagittal sinus that drains into the straight into this transverse, the transverse into sigmoid, and all of these sinuses drains into the internal jugular vein. Anterior view of these neck blood vessels. So we have external jugular vein here, and then here we have the common carotid, internal jugular vein, subclavian artery, subclavian vein. And then here we have the superior thyroid artery, branch of the external carotid artery. And then we have another one that is not shown in here, that's called inferior thyroid, that is branch of the subclavian. So this thyroid gland receives blood supply from this common carotid and also from the subclavian. And this, it's like the deep view so that you can see these blood vessels. And then here we have facial artery and veins draining into this area. Any questions? Thoracic arteries. So here we have the aortic arch and part of the ascending, which is this. So from the aortic arch, we have the brachiocephalic artery, left common carotid, and left subclavian. And then the left subclavian gives this internal mammary artery. And out of this, we have the anterior intercostals. And these intercostals run in between the ribs. That's why they're called intercostals. Now, thoracic branches of the aorta, themselves will be the bronchial arteries, and these are going to provide blood supply to the airways. And we have also esophageal arteries that is going to provide blood supply to the tube that brings the food from the stomach, from the mouth into the stomach, the esophagus. And also we have the posterior intercostal arteries that are going to anastomose with the anterior intercostals that are branches of the internal thoracic artery. And then above the diaphragm, laterally, we have the superior phrenic artery that provides blood supply to this area. Now, so what are the segments of the aorta? So this is ascending because it goes up, then this will be the arch, and this will be descending. And it's going to be descending thoracic because it's in the thorax, while this one that is below the diaphragm is going to be descending abdominal aorta. Lateral branches of the aorta will be lateral and posterior, the posterior intercostals, and lateral and medial, or middle, sorry, will be these esophageal and the bronchioles. And branches of the subclavian will be the internal mammary or internal thoracic artery. So here's the anastomosis between the intercostal arteries. So here is the aorta. The aorta runs on the left side of the spinal column, while the inferior vena cava runs on the right side. And then here are the intercostals. The intercostals run in the inferior border of the ribs, and they are in middle position. So they are flanked. So to the external side, you have a vein, the intercostal vein. It's not shown in there, but you have the intercostal vein more external, and then you have the artery. So here you have the vein, you have the artery, and you have a nerve. So it's vein from external to internal, vein, artery, and nerve. Why the nerve is more internal? Because it needs protection. It's more fragile, it's more important for function because it makes our intercostal muscles to contract so we can breathe. The second most fragile or more important structure will be the arteries. That's why it's deeper than the vein. And the less important kind of is the vein. So the vein protects the artery, and both the vein and the artery protects the nerve. And then when someone has fluid in the lungs, and then they need to extract the fluid or make a sample, take a sample of that fluid, the needle or the catheter is inserted on the superior border of the ribs, not the inferior border. Why?
Veins are
Hmm?
Is all the good stuff's on the inferior end?
Because you can damage this, right? The vein and the artery. So you use this superior border, not the inferior border. So then these posterior intercostals anastomose with these anterior intercostals, which are branches of the internal thoracic that runs on the sides of the sternum, deep. Okay? Thoracic veins. So we have here the bronchial veins that drains the blood from the airways, and these bronchial veins drains the blood into the azygos vein that is found on the right side. And then this azygos vein receives blood from the accessory hemiazygos vein that runs transversely. And then the left side of her body receives the blood from the intercostal veins into the hemiazygos. So these are the left posterior intercostal veins The left intercostals drain into the hemiazygos, and then you have the esophageal veins that drains as well into the azygos. So the azygos is on the right, and it is bigger or thicker than the hemiazygos or the accessory hemiazygos. So the blood from the right intercostals drains directly into this azygos vein. And the azygos drains into the superior vena cava, that it is formed by anastomosis of the left and the right brachiocephalic veins. The brachiocephalic veins are formed from the subclavians, which will be these, and from the internal jugular veins. So these two are the right and the left brachiocephalic that form the superior vena cava that drains the blood into the right atrium. And then here we have the inferior vena cava. Any questions? So, esophageal veins drains the blood from what organ? Esophageal, the esophagus. Most of the times, the names have a meaning. Abdominal blood vessels, the overview. So here is on the left side of the vertebral column, the descending abdominal aorta. On the right side of the vertebral column, you have the inferior vena cava. The abdominal aorta bifurcates or splits into two branches, the right and the left common iliacs. And this common iliac bifurcates or splits into internal iliac and into external iliac. So now the inferior vena cava forms from anastomosis from the right and the left common iliac veins. And the common iliac veins come from anastomosis from the right and the left, from the external and internal iliac veins. And now branches, anterior branches, three anterior branches of the aorta. Celiac trunk, superior mesenteric, and anterior mesenteric. So these are branches that goes like this, anteriorly to the front. Celiac trunk, superior mesenteric, inferior mesenteric. The rest are lateral, including suprarenals that are not shown in here, the renal arteries that provides blood supply to the kidneys, and then the lumbars and the gonadals. And then draining blood supply from the intestines will be the superior inferior mesenteric veins, and then superior mesenteric vein anastomose with some of these blood vessels like the splenic artery and vein, and then form the hepatic portal vein, which is this. And here we have the liver, the gallbladder, here the pancreas, and this is the large intestine. These are the small intestines. This is the spleen, this is the stomach cut, and behind here we have the kidneys. These are the adrenal glands. So this is the blood supply to the abdominal area. So let's look at the individual branches of the abdominal aorta. The celiac trunk, the first anterior branch, is called celiac trunk. And it's called celiac trunk because it's a large artery that is going to give several branches, smaller branches. Like here we have the celiac trunk. This is the origin, the superior part of the abdominal aorta just below the diaphragm. So this is going to give this first branch that is going to be the left gastric artery that is going to run in this part of the stomach that is called the lesser curvature. And then it's going to give this second branch that goes to the left behind the stomach, and that is going to provide blood supply to the spleen. So this artery is going to be called a splenic artery. So left gastric, splenic, and the common hepatic, which is the third branch of the celiac trunk, are going to be the branches of the celiac trunk. And the common hepatic is going to bifurcate to give you the hepatic artery proper that is going to provide blood supply to the liver, and it's going to give you the right gastric, which is going to provide blood supply to the stomach. And as well, it's going to give you the gastroduodenal artery that is going to be a small branch that is going to provide blood supply to the duodenum and the distal part of the stomach. So this common hepatic is called common hepatic because it's going to give you the hepatic artery, the right gastric, and then it's going to give you this gastroduodenum. That partly is going to run here in the greater curvature of the stomach, which is this. So this celiac trunk is going to provide blood supply to the liver, the stomach, the spleen, and the pancreas and the duodenum. So it's a large branch, that celiac trunk. And it's anterior, the first branch of the aorta abdominal. Now we have another branch, the second anterior, that is called the superior mesenteric. And this superior mesenteric is going to give you, it's going to bifurcate or give you several branches. So it's going to give you this middle colic artery that is going to provide blood supply to this part of the large intestine, which is the transverse colon. So that's one of the first branches of the superior mesenteric, the middle colic. And then it's going to give you the right colic that is going to provide blood supply to this part of the large intestine. This is the large intestine that is called the ascending colon. And then it's going to give you a branch that goes down and to the right that is going to be called ileocolic because it's going to provide blood supply to the ileum, which is the last part of the small intestine. This is the small intestine, and to the cecum, to the colon here in this area. This is the cecum. So this is the ileocolic artery. So those are some of the branches of the superior mesenteric. Now, out of these, we will have several small branches that are going to run in the mesentery, the membrane that holds the small intestines, that are going to be just simply called intestinal arteries. So what are the branches of superior mesenteric? Intestinal arteries, middle colic, right colic, and ileocolic. SMA, superior mesenteric artery. Now the inferior mesenteric artery, or IMA. So this one, which is going to be the last anterior branch of the abdominal aorta, the most inferior one, that's why it's called inferior mesenteric, is going to give you the inferior colic artery, which is this, that is going to provide blood supply to the part of the descending colon, which is this. And then it gives you some branches that is going to be called sigmoidal arteries that are going to provide blood supply to this S-like turn of the descending colon that now is going to be called sigmoid. And out of this, you will have another branch out of this inferior mesenteric, the superior rectal artery, that is going to provide blood supply to the proximal part of the rectum. So inferior mesenteric is going to give blood supply to the distal half of the large intestine through this inferior colic, sigmoidal arteries, and superior rectal. So 3 branches. Any questions? For abdominal veins, so you have abdominal veins draining into the inferior vena cava, which comes from the anastomosis of the right and the left common iliacs. And then you will have the inferior mesenteric vein that, together with the splenic and the hepatic portal, are going to drain together with this hepatic veins at this level in the inferior vena cava, or IVC. And then the renal veins that drains the blood from the kidneys, the right and left, will drain on the sides of this inferior vena cava. Renal gonadals, they drain directly into the inferior vena cava. The left gonadal, it drains into the left renal vein. So this is the right renal vein, this is the left renal vein. Left gonadal drains into the left renal vein, while the right gonadal on the sides into the inferior vena cava. And then here we have the superior mesenteric, and here we have the inferior mesenteric. Now, this common iliac come from the anastomosis of the internal iliac and the external iliac veins. They drain the internal iliac, the blood supply from mostly reproductive organs and internal structures within the pelvic area, while the external iliac drains blood supply from the femoral vein that is located in the femur, and then also from external portions of the pelvic area. Any questions for the abdominal veins? Hepatic portal system. So this system, it helps to drain blood from the intestines to go into the to the liver so that we can process the nutrients. So here we have the large intestine, this is the pancreas, this is the small intestines, this is part of the large intestine, and this is the inferior mesenteric artery, this is the splenic, vein, this is inferior mesenteric vein, this is the splenic vein. They both anastomose together with the superior mesenteric. So SMA, IMA, and splenic form the hepatic portal vein that drains the blood from the stomach through these gastric veins, and all of these form capillary veins that form the hepatic portal system. So nutrient-rich blood goes into the liver so that you can process the nutrients, either make proteins or store part of the nutrients as glycogen. And then the liver drains the blood into the inferior vena cava through these hepatic veins after you process the food. And then the inferior vena cava, together with the superior vena cava, drains the blood into the right atrium, part of the systemic circulation. Arm and shoulder arteries and veins. So here we have the median cubital vein that drains blood from the antebrachium, and that communicates these two veins, the cephalic vein that is external to the arm, and this vein that is medial to the arm that is called the basilic. So the brachial vein, which is in between the cephalic and the basilic, it will drain into the axillary vein together with the basilic. So here we have the radial vein, and this is the radial artery, and here we have the ulnar vein and the ulnar artery. So this median cubital vein crosses from the lateral side to the medial side and then drains the blood into this basilic, and then the brachial drains with the basilic, anastomosing, forming the axillary vein. And then this cephalic, which is lateral, anastomose this axillary to form the subclavian vein. And here we have the subclavian artery, axillary artery, and then here we have the brachial artery, and then here's the brachial artery in the antecubital area, radial and ulnar. Most of the arteries have the same name as the veins with few exceptions. Like, we don't have cephalic artery, and we don't have basilic artery. And cephalic, which the name doesn't make sense because, I mean, what a cephalic vein has to deal in the arm? Well, it was a misspelling from the original name, and they keep it like that. But one way that I remember that one professor told us to remember is that cephalic, it runs almost towards the skull, towards the brain. So think about like the most lateral to be the cephalic, while the most internal, the basilic, goes to the base of the armpit. So basilic, cephalic. And then we don't have basilic artery, we don't have cephalic vein. But we have brachial artery, we have brachial vein. And we don't have jugular artery, we just have jugular vein. And we don't have carotid artery. Sorry, we don't have carotid vein, we have carotid artery. So most of the names are the same with few exceptions. For arm, blood vessels. So at least, well, here they show the digital arteries and veins that runs on the sides of the fingers. These ones drain into the superior and deep palmar arches. And then these drain into the ulnar artery and into the radial artery. And here we have the radial vein, and then here we have the basilic vein, and then here we have the median antebrachial vein. So radial artery, radial vein, ulnar artery, basilic vein, and median antebrachial. Digital arteries, why, and veins and nerves, why they run here and do not run anteriorly or posteriorly? Why they run on the sides of the fingers? For protection. Imagine if you're carrying a heavy object like a bucket full of sand or water, what will happen to your fingers if you have any here? You stop the circulation, you have necrosis. So that's why we have it here on the sides for protection. Because we don't carry it this way. We're not dumb. We carry it this way. Okay? And now, this anatomy from these digital arteries and then these blood vessels in the antebrachium is not changing a lot. So most of the times within certain just changes in at different levels, we all have it the same. But these venous, superficial venous arches, they are unique. among people. And yeah, there's some genetics into it, but most of the time it's very variable. It's harder to find two people with the same anatomy in these superficial venous arches. Don't ask me why. Pelvic arteries and veins. So we have here femoral vein draining the blood into the external iliac, and then the internal iliac drains together with the external iliac into the common iliac right and left anastomose to form the inferior vena cava. We have here an anatomical landmark, inguinal ligament. Below the inguinal ligament, the external iliac changes its name into femoral. And then in here, of course, we have the arteries. So here is the external iliac artery, and then here we have the internal iliac artery. Internal iliac artery provides blood supply to deeper tissues within the pelvis, these two superficial tissues within the pelvis. And then it's not shown in here because it's not shown in here, but we have a median sacral artery there. And at articulations like the joint, the shoulder, the elbow, here in the pelvic area, we have these collateral branches that basically provide blood supply to the bones in this area. Like we have blood supply to the head of the femur, and sometimes when you have obstruction to these blood vessels, there's necrotic tissue here in the femur, especially in the elderly, and they break their neck of the femur really easily. So this is called avascular necrosis, and it's a major cause for fractures of the hip bone. Thigh arteries and veins. So here's the femoral artery. This is the deep femoral artery. So we have one that is not deep and this one that is deep. And then we have the longest vein in our body that runs from the ankle up to the groin. This is the great saphenous. It runs medially in the medial area of the leg and also in the thigh. This great saphenous drains here together with the femoral vein into the external iliac vein. So these two anastomosis form the external iliac vein. And this is just again the anatomical landmark, the inguinal ligament. Leg and foot arteries and veins, just as for the antebrachium, we have in the hand, so we have the digital arteries that provides blood supply to the toes and drains the blood from the toes on the sides of the toes. They drain into these venous arches, and then these arteries, the metatarsal arteries, forms the dorsalis pedis, the dorsalis pedis through this arch provides the metatarsal arteries and then the digital arteries that runs on the sides of the toes. And then these venous arches, together with the metatarsals, drain into these veins in the leg, which includes the lateral that runs from the ankle into the knee, which is the small saphenous. The small saphenous drains into the popliteal vein, which is behind the knee. And then behind the knee, we have also the popliteal artery. And then in here, we have the starting point of the great saphenous, which is all this. And then we have the anterior tibial vein and artery. And then here, posteriorly to the tibia, we have the posterior tibial artery and vein. Pulse points, dorsalis pedis, popliteal artery, where you can take pulse. femoral, radial, brachial, jugular, or carotid, common carotid, temporal, axillary can be pulse points. The most common one, the less invasive, will be radial. Upper limb veins, digital drains into palmar venous arches, the metacarpals as well receives blood supply from this area. And then you form the ulnar vein, the radial vein, which are deep. And then you form these superficial veins, the median antebrachial. And then they drain into the median cubital. And then you form the basilic, cephalic, and then the brachial that drains the radial vein. And then the brachial, together with the basilic, forms the axillary. So these are deep veins, axillary and brachial, in here in this area. And then this is the cephalic that drains into the subclavian together with the axillary. So superficial would be cephalic, basilic, median cubital, that's where you withdraw some blood samples. And then you have the median antebrachial, and then radial and ulnar. And then just a magnification of these venous arches. Dorsal is the one that you can see here. Another view of these veins without the arteries. So this is more like a medial view. So this is a posterior tibial vein. And this is the anterior tibial vein. And then this vein, the longest vein, the greater saphenous, that runs from the ankle up to the groin. So this is used to make bypasses in the heart. When someone has an obstruction, they take a piece of vein and then they insert it to make it like to be one of the coronaries or its branches. And this is the lateral view of these veins in the lower limb. So this is the medial plantar vein. This is the lateral. And this is the dorsal venous arch. So they drain into posterior tibial. And this is the small saphenous, again, just between the ankle and the knee joint. This drain into the popliteal. And here we have the great saphenous. And then here we have the deep femoral vein. And then femoral vein. And this will be the external iliac that together with the internal iliac form the common iliac. So clinical applications. So as we age, we lose elastic tissue. Makes our articulations to be less flexible, but our blood vessels as well, they are less flexible. This is called arteriosclerosis. So then there is a risk of having high blood pressure because they don't expand and they don't collapse as much, these blood vessels. So as we age, we can have an increase in blood pressure. Another thing that it can happen is that we can have deposit of lipids, calcium, and other molecules inside the blood vessels, and that occludes the blood supply. That leads to hypoxia. And then depending on the blood vessel, it's going to be the deficit. It can be in the brain, the person can have memory loss. It can be in the heart, the person can have angina first, if it's partial. If it's complete obstruction, will be myocardial infarction. So cell death of the cardiac muscle. And then some people can have weaknesses in the tunica media, in the blood vessels, and leads to a bulging of this blood vessel, especially during systole. When the blood pressure increases, the blood goes against this weak wall, and then sometimes this weak wall can rupture. So that would be what we call aneurysm, and that opening is going to be called the rupture aneurysm. That can lead to massive loss of blood and then the consequences. Some people can die out of that. Risk factors, sometimes some people born with it, but smoking, sedentarism, aging can lead to aneurysm. Common areas will be the aorta, especially the abdominal aorta, or some of the branches of the internal carotid in the brain. So if you have a rupture of one of these, will be a stroke. Test your knowledge questions. True or false? Arteries are more elastic than veins. Can they withstand changes in blood pressure much easily during systole and diastole? The arteries and the veins. True. Question number 2. Reading of blood pressure of 140/90 on 2 separate occasions is considered hypertension. True. True, true, true. Go to the books, go to American Heart Association, and they tell you that. 120/80 is normal, right? And then veins have valves that helps to move the blood toward the heart. True or false? True. Short answer. What are the 3 anterior branches of the abdominal aorta? CT, SMA, and IMA, which will be what? What are the full names? CT, the one that gives blood supply to the liver, to the stomach, to the pancreas and the spleen. Sounds almost like a name of a female. A female name. No, not Selena. Selena Trunk, no. Celiac trunk. SMA, what it stands for? I give you the abbreviation, just tell me what it stands for.
Superior?
Superior what? A stands for artery. So superior what? Mesenteric. Superior mesenteric artery. Then IMA will be what? Inferior. Complete name? Mesenteric artery. There you go.